Hello and welcome to the Auditing Antics podcast. So, Michelle, we're here in a chilly January day. Unfortunately, I've got my heated blanket here on my lap. I can't seem to get warm, but I'm sure it's much worse for you down in Florida.
I know. It's been in like the 50s and 60s, and for us, you have to understand that is quite cold. Like yesterday I woke up and looked outside and there was frost on the roof of the house behind us, which was very surprising. Uh
Yeah, and
I know,
concerning.
so treacherous conditions. What will we
Yes,
do?
yeah. Fun times. But today we're going to be jumping into remote patient monitoring. So I'm really kind of interested in this more so this year because we've got some changes. And, I've noticed the way that different companies are trying to sell their products. For those of you that are not familiar with remote patient monitoring, or RPM, that's what we're going to call it. Too long the other way.
Yeah.
With RPM, this has always been an issue where there's a lot of companies that will offer this as a service that a practice can sign up for. And a lot of times it's concerning from the standpoint of a main sales pitch that we hear. And Michelle, I know that you've heard that quite a bit. What is that number one thing we hear about RPM?
Ooh, passive income.
Yes.
It's you don't have to do anything and look at this revenue it's going to generate for you. If
Yes.
you
Yes.
hear that, run because there is no such thing as passive income in healthcare. If you don't have a part in it, if you aren't having your eyes on it, you should be concerned.
Well, and that's exactly the problem. And we've seen this up to this point already where the companies will come forward, they'll have all these sales tactics. I'll
Yeah.
give some examples here in a little bit of some crazy things that I've seen over the years. But now in 2026, we have a change where the code set and the code description changed a little bit because we have essentially an expansion now where we don't have to meet the minimum of the 16-day requirement. And a new CPT code has come out that's 99445. And that's saying that you can bill that new CPT code if you are monitoring for at least a minimum of 2 to 15 days. And this is pretty big because prior to 2026, when I would meet with either organizations that were trying to set up an RPM company, or if I was auditing RPM services, there was a lot of times where that 16th day had not been met and they're still billing it out.
Mhm.
And there was really, I don't understand why there was such a disconnect because to me, if it's in the CPT code description, it's so much more obvious because we don't have to dig through guidelines to find that as a requirement. And it says right there, 16 days. And
Yeah.
I would get clients saying things like, well, it's really hard. Do you know how hard it is to try to get a patient to get at least 16 days of data or to hook up to whatever the device is, 16 days, all of these different things that they would say. Or I have had clients in the past too where their workflow was off and the
Mhm.
time that they were looking at the patient account, they were just going ahead and having staff bill it at the time that they were reviewing things and it didn't meet 16 days. Sometimes it was 10 days or less. So going forward, we have a new opportunity because we have a new code with 2 to 15 days. But I think that with RPM, it's so much more than that we have to look at. The
Mhm.
description of the days, the time has to be there, all of that. But in this episode, instead of focusing more on the actual CPT codes, I want to talk more about essentially getting started. And
Mhm.
Michelle, you and I, we were talking about the fact that HHS has a website. You can go on, it's telehealth and remote patient monitoring. One
Mhm.
caveat, you do have to be careful because they have not updated that yet. So
Correct.
it was last updated January of 2025, so we don't have the new CPT codes in there. But
Mhm.
it has really good guides and instructions on what you need to know ahead of time. So, what devices you're purchasing, what your workflow is going to be, who you're hiring to do the work. A lot of these different things that play into the actual performance of the monitoring is where all of this tends to fall apart.
Yeah, and I think something really important to recognize off the bat is the management versus the monitoring are two separate things. And I think that's where people get confused with the billing, like you were saying, is they're trying to match up the management with the monitoring. And in all actuality, you have to treat those as separate parts of RPM. They have separate billing codes and they have separate types of requirements. And I think what you were speaking to earlier is people are going in and doing the management side of it and then thinking, let's just build the monitoring portion of it along with the management. And then you have a situation where the requirements aren't met.
Yeah. Yeah, and sometimes people were trying to do that. So we have one set of code or one code, for example, 99091. That's for the collection and interpretation of that data. And it requires a minimum of 30 minutes of time and it can be reported once each 30 days. So sometimes people would be looking to bill bare minimum. But the question is overall, if we look at the picture of that patient overall, what is the benefit to the patient or the benefit to
Mhm.
the plan if they're covering this as a service, if it's just the bare minimum and you're not actually fulfilling out everything that is meant to be a part of this set of services. And
Yeah.
I've really struggled with that because that definitely is something that becomes subjective, right?
Yeah.
We would probably see that play out in an external audit by saying that it's not medically necessary, and then we're left to argue from there. Uh,
Yeah.
I even had a conversation years ago that was very frustrating to me when I was nitpicking and going back and forth on RPM. The client at the time that I had was starting a new company. So, a lot of people, this rose out of the pandemic. So just like we saw with telehealth, a lot of people are like, "Oh, I'm going to do that now."
Yeah.
And the conversation I was having with my clients, they were getting frustrated because the way that they wanted to structure their company didn't fit in with the RPM workflow or what should be a workflow. And then on top of it, they had a healthcare attorney who advertised themselves as a health law attorney, really knowledgeable in telehealth and all these things. Remember here, we're talking about starting a company. And she comes into the meetings and she starts saying, well, we don't have to look at the report that the OIG just did of CMS. So if people don't know real quick, OIG will go in and do essentially audits on CMS. And they say, okay, these are where your policies are deficient. There could be fraud and abuse because you haven't given clear guidance here or you haven't done this. So we get more clarifying information when we look at what these OIG reports say. And for me in the work that I do, that's really important because if we think about the different levels of appeal, if you're under some kind of CMS audit, when you exhaust your appeal opportunity, you eventually would have to go up to the federal level, which could involve more of what's being stated in those reports. So it just was very frustrating to me because during the conversation, this attorney is saying, she literally was saying, don't listen to what the OIG says. That doesn't matter. And things like that. And I'm like, hello, last time I checked, the OIG is like this big watchdog of the industry. So why would we completely ignore it when we're trying to set a company up for success? And I've had conversations like that before with attorneys, and it really comes down to the fact of what you could defend and what would
Mhm.
cause you to do something that you would have to be defended. So it's not that what she was saying is wrong, but what she is saying is setting up that particular client to be in a situation where they have to spend thousands of dollars to be defended and still have that unknown component of whether or not they would win in the end.
Yeah.
So I say that because there's a lot of opinions in the industry on RPM. There's a lot of companies that skirt the line. And it's been my experience, probably because I do a lot of defense work, that when I'm seeing clients that are using companies that they outsource RPM to, there's always been an issue. It's either been an issue in workflow, documentation, or both. So it's something where, yes, to your point, Michelle, what we always hear, it can be passive income. It can be an additional service you can bring in for your patients. But this isn't the easy answer when we look at, the way reimbursement is, or the fact that
Mm-mm.
it constantly goes down, it never goes up. They cut things out all the time. This isn't the easy go-to answer that everyone thinks that it is. And I want to dig through that some now and talk about what some of those risks are. Now,
Mm-hmm.
Michelle, we were talking before this about some of the devices, for example. So could you give an overview as to, that important part about essentially how the data is captured, but then what about that transmission of the data?
So the devices have to be let me find the exact wording of it here.
Mhm.
It has to be considered a medical device according to the FDA, essentially. So if it doesn't meet the definition set forward by the FDA, it doesn't qualify for use. And then second thing for remote patient monitoring is it has to automatically transmit the data. We're not talking about devices where the patient collects the data and then enters it into a portal. This is something that will automatically transmit. We see blood pressure, weight, blood sugar, things like that automatically for the clinical review. Usually a clinical staff member is the one who is taking on the regular review of that data. So a lot of times I would say for me, what I've seen it most used for is blood pressure and weight. Those
Mhm.
are the two when I'm auditing that I see the most. So the device has to meet the definition according to the FDA of what a medical device is, and it has to also electronically transmit the data.
And that's a big point right there, because one of the things that I've found is when people are approached by different organizations, and I want to put a caveat out there, just like everything we talk about, a lot of times we're highlighting what we see that goes wrong in the industry because that's how we need to learn, right?
Hmm.
Other people, if they haven't experienced it, they're not going to know that this is a potential issue. So I want to say there are companies that are doing things correctly, but you have to
Absolutely.
go in and vet them, and you have to know what questions to ask to even know if they are valid and if they're, going to be problematic.
Yeah.
So I say that because with the transmission, a lot of times this is where we have the beginning of the downfall, because I'll go in and look at documentation and it says that so and so called the patient and so asked the patient if they did their vitals that day, if they did, what were their vitals, and then they'll show whether or not they have readings for that day. But the problem is we're looking at something that needs to be automatic. And when we have, for example, people that are calling and asking the patient, I feel like we're skirting way too close to that line of how the guidelines specifically state that this could not be patient gathered information.
Hmm.
So if you're asking the patient to give you what they have gathered themselves, how is that any different? And, again, I'm sure there can be arguments from the defense side, but that's going to be skirting that line very closely where someone's going to have to come in and defend themselves. And not only that, but a lot of the RPM companies that you find are offshore.
Hmm.
So, one thing that I find a lot of people don't realize is that when you are outsourcing, offshore becomes an issue if anybody is rendering care that is equated, that can be billed as a CPT code. So, what they're doing is directly related to a CPT code, and it's not billable unless they're doing what they're doing. So that's a problem because then we have healthcare that's occurring outside of the US borders because the person's in India or the Philippines or wherever they're located. And there's a huge difference between concerns we have with HIPAA or things like that with billing or coding taking place
Yeah.
offshore. This is a totally different thing. This is actual medical care that is being performed offshore. So then right there, it makes it so we don't have a reimbursable service. Now, a lot of times, like I said, the companies, if you look at them, they are typically, Indian based companies, things like that. So one of the questions you need to be asking if you're looking at implementing these services and outsourcing it is where are the centers located? So the people who are doing the work, where's the physical location? We don't care. We don't want to just hear where your corporate office is. Yeah, it's going to be in the US. That's not what I'm asking. With different times, it's been one of those things, and I'm not saying this in a derogatory way, but one of the ways that I've been able to identify that we have an offshore issue is the names of the people that are documenting everything. So if they say they call the patient, um, there's different cultures, right? There's different
Mhm.
names and different cultures, and it's a red flag. So then you go back and you ask, and they're like, okay, well, yeah, they don't have everybody here, or I just have a US contact. I don't get to talk to anybody else. All of those types of things are flags and a real issue that you have to look for because these companies are not always upfront about this part.
Mhm. Yeah, I think another red flag when, say, you've already signed up with a company, and a lot of them will say they're going to send you the documentation or upload the documentation into your system. You have to have that oversight in place to make sure that that is actually happening, because that would be another huge red flag if they're not getting that actual documentation over to you, because ultimately you are the one responsible for the compliance of that service. So that, that's another thing to be watching out for. Make sure that they are fulfilling what they are saying they're going to do. And that's not
That's
just
huge.
monitoring your patient. That's giving you all of the documentation and information as well.
Yep, and that's actually a really good point because I have a client that recently is going through some CMS audits in this area. And when they're asked, they have to provide the documentation. It's all being billed out under their NPI.
Mhm.
So when they're asked for that, they're like, oh, wait, our contract says it was going to be automatically uploaded and scanned into our EMR, but none of it's there, or just a little bit of it, just in the beginning. And then they stopped. So
Yeah.
then it became a problem because in the particular situation there, the the company that is providing this service is not using an actual RPM set of software. So that's another way you can gauge some of this. There are some really great companies out there that are
Yes.
making RPM software, and then they will also offer it as an outsourced service as well, in addition to their platform. Um, but it's kind of a red flag if you're asking for notes and it comes over and it's just typed out and somebody's name is just typed in and we can't really tell where this is coming from, who these people are, what their, background is, what their licensing is, any of those things. It's
Mhm.
just something anybody could have typed into, Word or Excel or whatever it may be. So
Yeah.
documentation is huge. And Michelle, I know from an audit perspective, that's a lot of times too where we find downfalls. It's not as bad now because a lot of people are starting to use the RPM softwares that are
Yes.
available. But before
Yes.
that, we would take a look at it and it's like, man, you're missing about half of that information in here.
Yeah, exactly. Luckily, I have been lucky in my recent RPM audits that, the clients that I have done audits for have used outstanding software where it, has everything you need. It highlights for the staff when thresholds are met and different things like that. It really did help automate for that. And I mean,
Mhm.
I tell you, it makes auditing a lot easier too,
Yeah.
because you're not having to try to find like, okay, go into the encounters and see where are the nurse phone calls and things like that. So there definitely is software and programs out there that can make this actually be beneficial to you from a revenue standpoint, but also beneficial to your patients from the oversight of their chronic condition on a more regular basis. So, something that does seem like a really good opportunity can very easily, as you have said with all of your examples, spiral into a compliance issue or an issue that's going to make you stand out to the people you really don't want to stand out to.
Well, and if we think about the whole picture of the patient, okay, yeah, we can have our checks, all of the boxes checked based on the guidelines of what needs to be there. But then the question is, well, what did you do with the information? How did this
Exactly.
benefit the patient? If there was a problem, what were the steps taken? If the patient's not even supplying the information and they're just calling and saying, hey, did you do your vitals? Like, what are those vitals good for? What are you
Yep.
tracking? Um, and, I've seen things, and this wasn't my particular client, but years ago, I remember hearing about a situation where there was this company that was RPM, it was an RPM company that were outsourcing everything, and they had scales, and they were going around to all these orthopedic practices and saying, hey, does weight affect your patients? Well, yeah, that's going to affect joints and everything, right?
Oh,
So they provide all these scales to everybody and they're tracking all of the weights. And when you look at the documentation from the RPM company that shows they're tracking everything, it's a constant overweight, overweight, high BMI, diet and exercise was instructed or whatever. But then you go into the orthopedic notes and there's no detail at all about the patient's weights. And remember, too, when we track back medical necessity,
mm-hmm.
they're not only going to ask to see RPM notes to look at medical necessity, they're going to want to see the notes of the ordering practitioner, the treating practitioner who's long term monitoring and treating that
Mm-hmm.
patient. So when you say you're doing it for weight-based reasons and then nothing even references weight, or the patient doesn't lose anything, the patient gains a ton of weight in the time frame, like what was the point when there's still no continued documentation from that orthopedic practice about what they're doing to help the patient with that? So it's just very frustrating to me
Yeah.
because it's one of these areas where it's so obvious people are doing it just because it's something that CMS will reimburse. Sometimes I do see that, yes, the treating practitioner is paying attention. They're making sure that they know what's going on with the patient. But it's also happened many times where, I'll say, well, what did you use the data for? When was the last time you saw the patient? And it's been a year or two, or the patient's
Yeah.
passed and they don't even know the
Oh,
patient passed away. And then the RPM company is still doing whatever they're doing. So
how? Whose data are they collecting?
I don't, well,
Did
when you
did
just,
the wife decide to, start
I
taking
mean,
their weight and
maybe
blood pressure?
when
Like,
when you just follow that manual process, it's very easy to get away with things,
I
if you
guess
think about
so.
it. Um,
Well, and that brings me to a question, Stephanie. With the new CPT codes and the lower thresholds, do you think that there's gonna be this uptick now of people thinking, great, we're gonna set everybody up for RPM because we only gotta meet 2 days for monitoring, and what is it, the 10 minutes um for the management code?
yeah, and
So
that I'm very
that I
concerned about that.
I really think that is an area where we cannot stress enough medical necessity. This is not just there has to be a need for it. If
And
if you're
usually there is a need.
but
So I
there
think
is,
more to your point in the beginning when you were talking about continued involvement, it's
yes,
not hands off.
no,
This
it's
is
not.
not passive income.
And even if you have hired on a company to manage this for you, you still have to have the oversight of seeing what they are doing for your patients. Does it align with what you have ordered for your, because you still have to place the order, they have to have the order for it. And does it align with your treatment plan and goals for your
Mhm.
patients? Or are we just going to have a bunch of, data out there without anything being done with it, just because all we've got to meet now is 2 days for the new threshold? And
Absolutely.
that is, I think that's what concerns me the most about, the sales pitches. That, I think, is what is going through my mind, and how often we see practices get these sales pitches, and it's like you hear about them and you want to cringe, because that's that person's job. They're in sales for a reason. They would
Mhm.
probably sell you the Golden Gate Bridge if they, if they could. It's, I don't know.
It's
I'm
like
not a
what
born
we talked
salesman.
about.
So,
Well, it's like we talked about with the skin substitutes. You cannot
yes.
trust the people coming to you. It doesn't mean that the companies ultimately are bad or that you can't
No.
work with them, because there's a lot of them that are good. They have a good service, a good product. But
Absolutely.
if they have a good product, they should be backing that up, and they should be giving you information that you can then go and vet external to that company and know, okay, yes, this is really good. And, to that point, I've done that before with clients where they want to offer a new service
Hmm.
and it's attached to a software. And I say, hey, great. Can I get on there with the person from the company? And then through conversation, I'm like, wow, they really do know the CMS requirements. They built this into their system. They do this, they do that. And it's a very positive thing.
Yeah.
But that's not the way it is across the board. And we have a whole issue with offshoring of things like we've seen in other situations. It largely exists in RPM.
Hmm.
So we have to be really careful. And to your point about the 2 days, that's why this came back on my radar again, because I had a client more towards the middle of last year that's dealing with quite a bit of issues with RPM, and then seeing the updates to the code set. As soon as I saw the 2 days, I'm like, well, crap, this is just going to explode. It's going to be all over the place. People are going to be going to conferences, and it's going to be, posed
Yum.
as the next best thing. So we've got to remember the continued oversight. Now,
Yes.
one last thing I want to mention, Michelle. So I am not sure if any other payers are doing this yet. I had seen updates from United Healthcare. I don't know, maybe it's just that United Healthcare is really good about pushing their information out publicly, but I tend to see a lot of their updates a lot more
Yeah.
than others. But we have new restrictions because United Healthcare has come out, and this is effective as of January 1st of 2026. So when you're listening to this episode, this is already in place. And UHC has basically stated that they don't feel that RPM is medically necessary for a large list of diagnoses. This is very important because if
Hmm.
we look at CMS guidance, they give us a list, but then they also say it's not an all inclusive list. So we don't know fully what we would have to argue there with CMS and Medicare. But United Healthcare is very specifically saying in this new policy that they will only cover this for heart failure, hypertensive disorders of pregnancy, and that's it. So
Hmm.
everything else like diabetes, hypertension, which that's interesting. They specifically put hypertension because that's a
Yum.
common one.
It's very
Um,
common.
yeah,
Same
behavioral
with
health.
diabetes.
Yeah,
Same with
yeah.
diabetes. And I can't help but think that they really reined in that list because of this new code, to put tighter, a tighter guideline around how it's really intended to be used, because
Mhm.
remote patient monitoring, the purpose is for you to be able to have that interaction with your patient on that regular basis, instead of having to wait to see them, at your follow-ups, however those intervals may be, 1 month, 2 month, 3 month, depending on, how the patient is doing. So it's supposed to allow you to address concerns that you might have. Like, I think of a heart failure patient and a sudden increase in weight. That can be really telling to a physician and really concerning. So it's just, it's interesting to me that they've brought that right in and said only these two things
Yeah.
we will
Yep.
cover it for. And I think it's because they have those same concerns we have about the lower thresholds.
Mhm. And just so everyone knows too, so remember when you're researching different policies, you've got to make sure that you are looking at whether or not it's nationwide, specific to a state. It's all
Yes.
going to depend on payer and how that plan is administered. For this particular one that's effective January 1st, it does specifically say it's for commercial and individual exchange medical policies. And then additionally, it says for that individual exchange, it's valid in all states except for Mississippi.
Hmm.
So I just bring that up because when you research, you got to make sure they're going to have different plans for community, which means that that could be like a Medicaid based plan. They're going to have them for Medicare Advantage as well. So there's different policies that will
Yeah.
exist for these
And
payers.
and of course, in the one that I have up, they have links to those, but they don't work.
Oh, of course. Of
Of
course.
course. I just tried clicking on it because they have like a link for community plan policies and a link for Medicare Advantage plan policies. And he's like, how convenient. Well, I guess not.
Yeah.
So you
Yeah.
might have to dig
Joke's
a
on
little for
you.
those.
All right. So to wrap this up, just the key message here, just like you've heard from us in other episodes, is that you've got to make sure that you're paying attention. It's not that these things are not going to add to your practice or your
Hmm.
organization. You shouldn't automatically just shoot that down and say no if you have a physician who's wanting to start a certain program or things like that. But there's proper ways to go about that and vet it and make sure that you are covered so that you're not having to pay for it on the back end.
Absolutely.
So that we're going to go ahead and end there for today. I just wanted to give a quick update too. Again, I know I had mentioned this in the past, but we're continuing to see a lot of growth in the podcast, which is great. I feel like we're definitely getting some information out there in a different way than,
Hmm.
just a typical written form or things like that. And it's been a really positive thing. So make sure if you're listening on a different podcast app, go in, like the show, subscribe, and follow to that. Share the episodes. You can rate the podcast as well. If you are on YouTube, you can subscribe to the channel there. And, LinkedIn, you can share. So whatever method you like to listen to us in, there's a way to get that out there and share with people that or people that you're connected with. So I appreciate that and looking forward to a lot more growth in episodes in 2026.
Absolutely.